My name is Charl Els and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine, Department of Medicine at the University of Alberta. This session focuses on Major Depressive Disorder, or MDD, usually referred to simply as depression, and its occupational impact. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare, and the opinions expressed in this presentation reflect those of the speaker and not necessarily those of any collaborator or funding agency. The session provides a brief outline of the features of MDD, including causation, prevalence, diagnosis, and prognosis. It offers very brief comments on treatment, and it addresses the occupational impact, that is the impact of MDD on capacity, risk, and tolerance. At the end of the session, participants will be equipped to recognize MDD as a common and occupationally relevant medical condition, describe the impact on occupational capacity, risk, and tolerance, and thirdly, outline evidence-based interventions to achieve maximum medical improvement, or MMI. Although the word depression technically refers to a symptom that occurs in more than 40 different mental disorders, it's often also used to refer to one specific diagnosis, that being Major Depressive Disorder, or MDD. MDD is a diagnosable psychiatric condition classified along with disruptive mood disorder, disruptive mood dysregulation disorder, persistent depressive disorder, or dysthymia, which is a more chronic and persistent form of depression, usually lasting 2 years or longer, and then premenstrual dysphoric disorder. There exists a large number of substances of abuse, some even prescription medications that can be associated with depression-like symptoms. Further, many medical conditions can be associated with depression-like phenomena. MDD is characterized by discrete episodes of at least 2 weeks duration, and which involves demonstrable changes in functioning, including affect, cognition, and neurovegetative functions. Although the criteria in the DSM-5 suggests that episodes last at least 2 weeks, they most commonly last much longer, and you only need one of these depressive episodes to diagnose MDD. Most persons in the general population may, of course, at times experience a sense of sadness, an irritable or depressed mood, lasting for varying periods of time, and which could be completely normal and a necessary part of our emotional homeostasis. Bereavement and MDD can, of course, co-occur. There are several psychological theories and a variety of biological theories that aim to explain the causal factors involved in the development of MDD. Like with most psychiatric conditions, the exact cause is not known, but a biopsychosocial model applies with predisposing factors, precipitating factors, and modulating factors. And of course, genetics play a fundamental role in the causation of mental illness. MDD involves the likely disturbance in levels of the neurotransmitters serotonin, dopamine, and norepinephrine, and there have been identified a few risk factors, including select personality constellations, gender, especially female, a family history, roughly doubling the risk of MDD, bereavement, alcohol and drug abuse, as well as a history of childhood trauma and sexual abuse. Depressive disorders, including MDD, are common, with the highest lifetime prevalence rate of any psychiatric disorder, that being 5 to 17%. Women are more commonly affected than men. The diagnosis is made by taking a comprehensive history and performing a physical exam to rule out medical problems that may be causing or contributing to symptoms of depressed mood. For the diagnosis itself, the physical examination is usually non-contributory, and special investigations are conducted only on merit of positive findings. For example, a thyroid function test is key. An evaluation that includes psychological testing may also assist in the diagnosis, as do rating scales, for example the PHQ, the BDI, and several others. And these are used to detect the presence of MDD symptoms, to measure the severity of the condition, as well as to monitor response to treatment. MDD is a clinical diagnosis with no single definitive diagnostic test. Using the criteria in the APA's DSM-5 allows for a diagnosis to be made with a reasonable degree of certainty. According to the DSM-5, a major depressive episode is diagnosed when a person experiences 5 or more of the symptoms during the same 2-week period, and this represents a change from previous functioning. The symptoms are at least one of the following: depressed mood or loss of interest in pleasure. Then the DSM-5 suggests that the remainder of the symptoms are, and I'll go through them briefly: depressed mood most of the day, nearly every day, as indicated by either subjective report, that being the individual complaining of feeling sad, empty, low, blue, hopeless, or objective observation made by others. For example, the individual appears tearful. Secondly, markedly diminished interest in pleasure activities, in all or almost all activities, most of the day, nearly every day. And this is indicated either by subjective account or by objective observation. Thirdly, there's significant weight loss when not dieting or gaining weight. For example, a change of more than roughly 5% of the body weight in a period of 1 month, or a decrease or increase in appetite nearly every day. 4, insomnia or hypersomnia nearly every day. 5, psychomotor agitation or retardation nearly every day. And this could be observable by others and not merely subjective feelings of being restless or being slowed down. 6, fatigue or loss of energy nearly every day. 7, feelings of worthlessness or excessive or inappropriate guilt. And this may actually reach delusional stages nearly every day. And this is not merely a sense of self-reproach or guilt for feeling sick. 8, diminished ability to think or concentrate or indecisiveness. And again, nearly every day, either by subjective account or as observed by others. 9, recurrent thoughts of death or dying, and this is not just a fear of dying. There could also be recurrent suicidal ideation without a specific plan, or there could be suicide attempts or a specific plan to commit suicide. To meet the diagnostic criteria, the DSM further suggests that the symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. And the depressive episode is not simply attributable to the direct physiological effects of a substance or another medical condition. In the occupational mental health context, the diagnosis of MDD is reliant on careful observation, obtaining a detailed history, and getting collateral information, and at times conducting validity testing where appropriate, as well as the completion of these special investigations and tests based on the merit to rule out physical conditions. Regarding the ability to work, risk, capacity, and tolerance are assessed. The association between depression and lost productivity has been consistently documented in both epidemiological as well as research studies. In all cases, risk of harm to self or others, as well as occupational risk, needs to be assessed and addressed on own merit and as a matter of priority. One key consideration here is whether there exists a major risk of violence or aggression. Simply by virtue of the diagnosis of MDD, individuals suffering from this condition do not pose a disproportionately increased occupational risk when at work. Cognitive symptoms associated with MDD may result in capacity impairment, that being impairment in alertness, attention, concentration, reaction time, and several other cognitive domains, which may well preclude safe and predictable execution of tasks in safety-sensitive settings. Some medications used for the treatment of MDD may actually increase sedation and may also increase occupational risk. Further, comorbid substance use disorders may increase or contribute to risk as well. Usually in the absence of paranoia, suicidality, and substance abuse, the occupational risk associated with MDD is not considered meaningfully increased. In particular, symptoms that are problematic include those of social withdrawal, lack of motivation, low frustration tolerance, lack of consistency, fatigability, insomnia, impairment in judgment. So remission of the MDD is usually required in order to return to safety-sensitive work, but typically accommodation in a non-safety sensitive position may be beneficial to achieving recovery. Occupational tolerance may be diminished as a result of MDD, but this usually improves with treatment over the course of time, that being applying medication and psychotherapy interventions. Important to remember that work is usually therapeutic and does not cause mental illness. MDD is a chronic construct. The majority of persons with one MDD or one episode of MDD will suffer at least one more depressive episode. Further, while those individuals with a history of 3 previous major depressive episodes will have a 90% likelihood of having a 4th episode. Remission may be spontaneous in a matter of months for some, but treatment is routinely indicated for most people with MDD. With treatment, the prognosis is usually optimistic and the vast majority of persons are able to return to pre-morbid occupational functioning. Just like not every person with MDD is unfit to work, not every person who is sad needs medication. Treatment for MDD consists of a combination of pharmacotherapy and psychotherapy, and different talk therapy modalities are effective for the treatment of this condition. And perhaps the best support is for cognitive behavioral therapy, or CBT. Many different medications from different classes have been proven to be safe and effective, and this includes SSRIs, SNRIs, atypical antidepressants, MAOIs, and several others. And there are strategies to implement for when treatment with medication does not result in full remission. Different circumstances also call for different interventions, as well as for the treatment of special populations. Maximum medical improvement is usually reached within weeks to months. Please have a look at the 2016 Clinical Practice Guidelines for the management of adults with major depressive disorder, and details can be found at canmat.org. Depression is a common chronic relapsing condition, and it reflects much more than simply a sense of feeling unhappy. Depression is a salient public health issue and an important contributor to occupational impairment and disability. Most persons with depression can indeed continue to safely and effectively work, with some exceptions, and in some cases with attention to restrictions and limitations, as well as suitable accommodations. Finally, work does not cause depression. And as a matter of fact, work may in most cases be considered psychologically beneficial. We've included a list of resources which we hope may be of assistance. Thank you for your attention. We look forward to your feedback and comments, and please help us identify further topics for further discussion. Thank you.